Good morning, all. Today, Dr. Ramu is the consultant in critical care hospital in Visakhapatnam. Is going to talk on pleural effusion, a big, broad topic. He will analyze and he will. He is a pulmonologist basically, so he will do the clear picture on pleural effusion. Thank you, Ramu, for accepting a very short time.
Thank you, sir.
You start the presentation. Thank you.
Thank you, sir. Good morning, Mohan sir. Good morning, David sir. Today my topic is pleural effusion. Theoretically, it is very big, but diagnosis, coming to the diagnosis, it is very everyone thinks it is very easy, but it is always a dilemma for if you will not take proper history. Coming to the definition, it is an abnormal accumulation of the fluid in the pleural cavity. Like this was the X-ray which shows like massive pleural effusion shifting towards the right side mediastinum, and it is a homogeneous opacity. Like pleural fluid, normally it the amount of pleural fluid in the pleural space, it is around 2 to 20 ml, and based on by visualization, like based on the ultrasound, normally above 50 and 100, it is betterly visible in the ultrasound. Where coming to the chest X-rays, we can visualize only the blunting of costophrenic angles if the fluid is around 200 to 300 ml. And by clinical examination percussion, around 300 to 400 ml. And if it is present more than 400 only, then we can, by percussion only, we can detect, or else it is very difficult. Like coming to the anatomy, it is an coupled organ between the lung and the chest wall. It does not exist in all mammals. Like now, commonly in mammals, we see is in sheep, it is existing. Around 30% of the all respiratory disease may be associated with pleural effusion. There are two parietal pleura and visceral pleura, but secretion, mostly secretion and reabsorption from the parietal pleura only, but less with visceral pleura. Types of effusion, there are two types, like transudate and exudate. Coming to transudate, it is occurs mainly, the main pathophysiology. I am telling about the pathophysiology. Like it occurs as a ultrafiltration of serum across the pleural membrane and resulting from imbalance of hydrostatic or osmotic pressure, like increasing hydrostatic pressure and decreasing oncotic pressure, which enables to remain the pleural fluid in the intrapleural space, which leads to, there will be a fluid shift of interstitial into the pleural space, and it leads to effusion. Normally, transudates, like we see in heart failures, cirrhosis of liver with ascites, and renal failures, nephrotic syndrome. Coming to exudate effusion develops as a consequence of inflammation or a malignant disorders, such as pneumonias, cancers, or tuberculosis. Basically, here what happens is the microorganism which leads to inflammation forms when the microorganisms interact with the foreign bodies, inflammation starts. This inflammation leading to these inflammatory mediators leads to vasodilatation and increased permeability, and allow all the larger molecules weight and compound to enter into the pleural space. Detection of an exudate often requires additional tests, may be invasive in nature or non-invasive. By appearance of pleural fluid, like pale yellow, when we see the pleural fluid, like after aspiration, by seeing only we can differentiate whether it is exudate or transudate. And most of the pale yellow straw is transudate. Some only will be exudate. Coming to red, like bloody, always we should think of malignancy, benign asbestosis, pleural effusion, pulmonary infarcts, and trauma. Coming to hemothorax, whereas when we measure the hematocrit more than 50%, it is likely to be a trauma or malignancy. And white is always chylothorax or cholesterol effusion. Brown is amoebic liver abscess, and black is spores of the aspergillosis. Coming to yellow green is the rheumatoid pleurisy. Color of enteral tubes, feeds, or central veins line infusate. Feeding tubes has entered the pleural space where there will be a extravasate catheterization migration into the mediastinum that we can see clearly, and this can be detected in the pleural fluid. And always the appearance, if it is pus, we should think of empyema, and if the fluid is viscous, then it is mesothelioma. Debrates rheumatoid pleurisy. Turbid is inflammatory exudate or lipid effusions. Anchovous pus is amoebic liver abscess. Order, based on the order, like whenever any patient who is having the pitride, like when we enter into the water, when we aspirate, they will have a halitosis smell. By the smell only, we can tell that is a anaerobic empyema and anaerobic infection, basically. And ammonia is urothorax. Exudate pleural effusion. Diagnosis based on the Lights criteria. Lights and colleagues studied the diagnosis performance of the 3 pleural fluid tests. Out of this, like a positive finding of one of the tests established the presence of exudate. Pleural fluid to serum protein ratio more than 0.5, or if pleural fluid to serum LDH ratio more than 0.6, or if pleural fluid LDH concentration more than 200. Now later it is changed to 2/3 of the upper limit of the normal fluid, from the serum LDH. And sensitivity of the fluid, always sensitivity of this, based on this pleural fluid test, sensitivity has been around 99%, and the specificity is around 98% for identifying of a exudate. Subsequent studies has confirmed that a highly sensitive of Lights criteria, but reported a lower specificity around 65 to 85%. As the number of the test increases, like when we increase the test like 2 times, 3 times, the identification target like sensitivity increases. Same like yield also of the positivity also will increases. But likely incorrect of identification, another cause, false positive results also increases and lowers the specificity. As a general rule, combining single or independent tests always results in the increased sensitivity and decrease the specificity. Coming to transudate pleural, none of this meet the above criteria. Then it is like we have to think of only transudate. And other one is serum to pleural fluid albumin gradient. Roth and colleagues evaluated the performance of the serum to pleural fluid albumin gradient. Serum to pleural fluid albumin gradient, if it is around 1.2 gram per deciliter or less, then we should think of always exudate pleural effusion. And other thing is like the sensitivity is 95% and specificity is around 100%. This test decreased the misclassification. Like whenever this test was done in a patient with heart failure, already used diuretics, then the gradient will be change. We cannot take this gradient as a normal like exudate. This was observed prominently recommended to perform albumin gradient test for the patient which seems to be clinical likely transudate secondary to the heart failure, but have borderline evidence of a exudate when the test is tested with by Light rate. Other thing is pleural fluid cholesterol. Ham and colleagues shown the exudate having higher cholesterol concentration compared with the transudate. Likely explanation, they have been breakdown of this. Basically, this cholesterol, the breakdown of intrapleural cells, which release the cellular content of the cholesterol, and to increase the which leads to increase in the capillary permeability, which allows the cholesterol into the bloodstream to enter into the pleural space. Exudate or cholesterol more than 60, Ham and colleagues shown the sensitivity is around 100% and the specificity is around 95%. There was a meta-analysis, the cutoff, the value of around more than 45 they have taken. And the investigator also noted that pleural fluid to serum ratio cholesterol using the cutoff point is 0.3 for extrat, and highly sensitivity 93%, and the specificity is 88%. The other tests which all uses for the differentiate from extrat from transdat, like uric acid, the cutoff value is 5.8. If it is more than that, it is more in transdat. There is less, it is extrat. And CRP, C-reactive protein, less than 0.6 grams per day, milligrams per deciliter, it is transdat, and more than 1.3 is milligrams per deciliter is extrat. And coming to alkaline phosphatase, less than 975 milligrams per deciliter, it is transdat, and more than is 75 is extrat. Other tests like aniline transaminase, creatine kinase level more than 35 international units, pleural fluid to serum cholesterol, what I have told before, and aspirated transaminase, interleukins 1 beta 6 8, and TNF alpha, tumor necrosing factor alpha, and gamma interferon, gamma glutamine transferase. These all tests which basically used for differentiate from extrat to transdat. Mostly all these all are not routinely not used, but it may use in the differentiate from extrat to transdat. Like these all the other baseline values which can tell on this base whether the pleural fluid is extrat, most of extrat. Like specific gravity, if you measure, then if it is more than 1.015, then it is transdat. And pleural fluid protein, already I have told. And gradient less than 1.2, cholesterol more than 45, and pleural fluid to serum cholesterol ratio more than 0.3, and pleural fluid to serum albumin ratio more than 0.6. Like to summarize this, most of the transdat can be picked by the history and physical examination. And by taking the proper history, whether the patient is having cardiac or any cirrhosis of liver, based on that history only we can tell whether it is transdat or extrat. Mostly, like if it is they are having cardiac history, then it is transdat. And clinical situation justifies that extrat, no need to do all the tests to confirm the extrat. Etiology, always it is very useful to evaluate the based on the etiology only we can go whether which side, whether to transdat or extrat we can tell, and based on that if it is extrat we can do a needs of specific test. These in coming to the etiology, like transdatic pleural effusion, transdatic pleural effusion, exudative pleural effusion. Like transdat, what I told is congestive heart failure. It basically in congestive heart failure around we can see more than like around it will be around 36%. And cirrhosis of liver, peritoneal dialysis, nephrotic syndrome, and superior vena cava obstruction, mixed edema, pulmonary embolism. Pulmonary embolism around 8%, and commonly we see is other one is parapneumonic effusions, like pneumonia. So pneumonia with effusion, what we call is a parapneumonic or pneumonic effusion. Normally it will be around 22%, but initially there will be a transdat, but most oftenly we can see extrat only, because by the time they come with pleuritic pain, they change into extrat. Other causes like infective disease, bacterial infection, tuberculosis, fungal, viral infection, parasitic infection, these all are comes under exudate pleural effusion. And pulmonary embolism, gastrointestinal disease like pancreatitis, esophageal perforation, intra-abdominal abscess, collagen vascular disease, rheumatoid arthritis, SLE, lupus erythematosus, Chokes-Strauss syndrome, drug-induced pleural disease, nitrofurantoin, dantrolene, and bromocriptine, all these drugs, amiodarone, these all comes under exudate pleural effusion. Asbestos exposure also it comes under chylothorax, hemothorax, post surgeries, sarcoidosis, post cardiac injuries, uremic pleuritis, and yellow nail syndrome. Based on the X-rays, we can normally previously they used to grade like moderate, mild, moderate, and severe. the above three X-rays, first one is the mild pleural effusion, and second one, uh, it is moderate pleural effusion, and this is massive pleural effusion. And this X-ray shows effusion on the left side, but it is very less. By visualization, we think the effusion is very less. But when we check for the lateral decubitus, left lateral decubitus, we can see the line down. It is like more than, if it is more than 1 mm, sorry, 1 mm, then we should the amount of fluid will be around more than like around 5 to 10 ml pleural fluid. It can be mostly demonstrated by lateral quick test. Nowadays, no one is using, but previously we used to do like this only. And by CT, this is the CT, the same patient only. And when we get the CT, the left side pleural effusion was like this. So it is like always getting CT, chest X-ray, and lateral decubitus. It is very like based on the cost and radiation. Nowadays, ultrasound is like more commonly used, as it is very feasible, and it is less radiation and less cost. Based on that X-rays, we can treat how we can treat the based on the X-rays. If it is mild, moderate, and severe. If it is mild, normally thoracensis, normal pleural tap is sufficient enough. Whereas coming to moderate, based on the etiology, always some patients we can do like pleural thoracensis, but in some cases like empymas and all, we have to go for ICDs. Coming to massive pleural effusion, always there is a need of one tube thoracostomy is needed, but one always it may not be sufficient. Normally, one anterior and one posterior is always the best to treat in such patients. Clinical features, like most of the patient, they come with asymptomatic and they are associated with breathlessness, but they come with the dry cough or pleuritic chest pain, which is suggestive of pleural inflammation and a heaviness of the chest, or else like pain referring to the shoulder or the abdomen. Always by clinical examination, we can most of the patient, if they are moderate and massive effusions, we can tell the based on the clinical examination, like seeing the chest expansion, and when we put a step on that, it decrease tactile vocal firmness, and by percussion stony dull note we can note, and quiet breathing sounds we can hear, or else like one time if there is any fluid like hydropneumothorax, then we can hear a bronchial breathing above the fluid level, and based on that we can tell it is a other diagnostic test is suction splash. Based on that also we can tell it is a hydropneumothorax. Suction splash is just a similar like example we can give, like half when we take a bottle and water with air, when we shake that same like that only in the chest, in pleura, when we shake this hydropneumothorax, we can hear that sound. So based on that, we can then tell that it is a hydropneumothorax. And the other thing is when it is a inflamed pleura, that they will have a pleural friction pleural rub. Coming to the investigations, always detailed history is more beneficial. And chest X-ray, what I told, and pleural analysis. Pleural analysis normally based on the cytology. There are different initial site, different etiologies with different pictures they will give. Normally, if it is infective, always it is exudate and neutrophilic predominance. Whereas coming to translate, there will be a new less counts, and neutrophil predominance will be very less. Normal it could be, and it could be one time it is lymphocytosis, mild lymphocytosis. And in some cases, like eosinophilia, more than 10% in pleural fluid, it's always it's suggestive of air or a blood. Whereas coming to, if there is no air, like if we think if it is there is no air, only fluid is there, then we should think of other etiologies like fungal parasites, drug induced, or pulmonary embolism, or like what I told previously, asbestos or Chalk-Strock's syndrome. And other tests in pleural fluid, like in tuberculosis, like lymphocyte predominance more than 50% with tuberculosis, as well as in malignancies, we can see. Whereas coming to mesothelial cells, always mesothelial cells, if it is now more in number, mesothelioma, where it is when it is more also, we can exclude the tuberculosis. And other cells like plasma cells will be the suggestive of multiple myeloma. And LDH always it is an indicator for pleural fluid inflammation. When we take the LDH, repeat LDH also we can do. If there is an ICD or pleural tapped catheter, if you send every alternative or 3 days, by based on the LDH, we can tell the inflammation is coming down or not, we can tell. And other thing is glucose. Glucose is always less than 60. Think of always tuberculosis, malignant pleural effusion, rheumatoid arthritis, and parapneumonic effusion. When the parapneumonic effusion always, if it is less than 60, if the patient coming with parapneumonic effusion and the glucose is less than 60, on top of that, if it is the pH is less than 2, if it is moderate to massive, moderate or massive, then we should go for the treatment is the tube thoracostomy. That is the ideal indication for the tube thoracostomy, where we can directly go for that treatment management. And other cases like empymas and malignancies, there the pH will be less than 7.3, and collagen vascular disease also it will have a pH less than. And other paradigm, what I told is with pH, low pH and glucose, the LDH will be very high in that patients, like parapneumonic efficiency. Ultrasound, everyone knows that ultrasound, it has a major role in ICU as well as now day-to-day practice. Whoever the patient who with coming with pregnancy with pleural effusion, always the best ideally diagnose for diagnosis is ultrasound. CT always it is best, but it is having radiation and expensive. But in some circumstances, like if there is a lung abscess with empyema, always to differentiate, it is very difficult with ultrasound or the chest X-ray. So in certain cases, we have to go for CT. And coming to pleural biopsy and VATS, based on the pleural biopsy, solely the yield of the diagnosis will be increased. Like with pleural analysis with combined with pleural biopsy, the yield will be diagnosis will be increased. VATS always it has its own role. Only in the cases of empymas and undiagnosed patients, pneumonia with effusions, VATS plays a major role, and it aids in the treatment of decortication and decortication, and as well as any fibrin stents also can be removed by VATS and diagnostic and as well as therapeutic and diagnostic mechanism. This is the flow chart where based on this we can evaluate the pleural effusion. Like etiology, first if we are unknown, based on the color, protein, cells, and we can if their etiology is not known, we have to go for directly blind. If the cells or anything we cannot pick it up, then we have to go for blind pleural biopsy. Nowadays, blind pleural biopsy, they are not routinely practiced, but best is thoracoscopic included biopsy. Almost if based on this approach, if we'll do also one time, we may not diagnose some pleural effusions. Etiology will be very undiagnosed in like 5 to 10%. Coming to entities like tuberculosis, this is one of my case. Patient has come with chest pain and fever since 1 week. 1 week fever and on and off, but only subsided fever in initially 3 days, and only once in evening, like fever raised 1-2 days, and he had a pain with chest. Then only he came to OPD. With X-rays, we think, but there is no pleural effusion. But upper mediastinum a bit widening is there, as well as here on the right basal there is a blunting of costophrenic angle, cardiophrenic angle. Got the CT, that same patient only, we had a pleural effusion. It is basically with history and analysis, it was correlating with tuberculosis. Always tuberculosis initially when we aspirate it, it appears to be very clear and a straw color, but later on it will go into after 2 weeks, like it changes, the color changes. Initially clear color, later on straw color, yellow color, it changes based on the concentration. And the effusion always after 1 week, initially neutrophilic predominance, and later on virtually always it is extended pleural effusion. Glucose, what I told, initial stages, what I told is the differential count is always very difficult. It is neutrophilic predominance, but later it will be lymphocytic predominance. Coming to ADA, ADA is an enzymatic enzyme in the purine salivary pathway that catalyze the controversy of the adenosine and de-adenosine to ionize, and deoxynoise with the release of ammonia. Pears and colleagues in 1979 first time reported high level of ADN with tuberculous pleural effusion. But they determined the ADA like level initially, it was 70 is highly suggestive of tuberculosis. But the level has been around now 40 virtually excludes the diagnosis. These all are the etiologies where there will be a ADA rich, ADA in lymphocyte rich pleural effusion, like empyema, rheumatoid arthritis, bronchoalveolar carcinoma, mesothelioma, mycoplasma and chlamydia pneumonia, psittacosis and paragangliosis, infection mononucleosis, brucellosis, Mediterranean fever, histoplasmosis and coccidiomycosis. There are two types, two ADA1 and ADA2. ADA1 is found in cells where there is a highest activity observed in the lymphocyte and monocyte. ADA2 is predominantly in the monocyte or macrophage. ADA2 is isomer to be the primary responsible for the increasing of ADA activity in the tuberculosis effusion. So always ADA1 by ADA2 also, ADA1 total ADA ratio 0.4 makes the diagnosis of high likely tuberculosis. Interferon gamma produced by the T lymphocyte is capable of activating of macrophage, increasing the bacterial capacity against the Mycobacterium tuberculosis, and is involved in the granular form. Elevated interferon levels and hematological malignancies and empyema. These all where we can, these two entities where we can see elevated interferon levels. And immunosuppression like HIV and transplants, interferon is similar to immunocompetent individuals, retain the efficiency of the diagnostic test. And pleural fluid levels more than 150 indicates the tuberculosis, where meta-analysis showed around from 1978 to 2000 concluded that ADA and interferon appears to be reasonably accurate in diagnosis of tuberculosis with the specificity of 93% and for ADA and 96% for interferon. Coming to PCR, polymer chain reaction is based on the amplification of Mycobacterium DNA fragment. This is routinely used normally to put PCR also. There, if it less than 10 Mycobacterium also, the PCR will be. Always it is more sensitive, but it is specificity is also not that much. Around 90%, but sensitivity is more. It will pick the dead bacillus also one time. So it is very one time to conclude whether it is tuberculosis. It is very difficult. What numerous studies have shown PCR diagnosis of pleural tuberculosis sensitivity range around 20 to 90%, and the specificity is 78 to 100%. The sensitivity of the nucleotide amplification technique depends on number of Mycobacterium and the presence of amplification inhibitor, type of primer used, and genotype sequence amplification. Based on this only, the sensitivity and specificity will vary. And causes always cause of false positives like DNA contamination or presence of non-viable organism, what I told previously. And PCR is always with biopsy also we can prove that that's what I told, the yield will be increased based on the tissue biopsy, where the sensitivity is 90% and the specificity is 100%. Disadvantage of PCR is a very high cost now, but still nowadays routinely it is used. It is not a major problem. And contamination, it is a basically it is very difficult to, that is also making the one time patient PCR is positive and patient is always abnormal, like normal, no asymptomatic. So it is difficult like in such times. Pleural biopsy, this is the hook needle where we used for closed biopsies. Here with pleural effusion biopsies, the yield will be increased like 39 to 80%. Always it is previously it is used for closed biopsies. Coming to open like thoracoscopic, like where we used for when the diagnosis is very uncertain. And yellow on the mostly the we can see the additions in the parietal pleura, and the color will be like a yellow white tubercle. And when we there if the additions will be numerous, from there only we have to pick and send for biopsy. And always target biopsy suspicious lesions and which are most concentric in the costovertebral angles. Thoracoscopy is most accurate, most expensive and tool for diagnostic, and diagnosis accuracy is 100% and 76 positivity of culture. Other cytokines can be used like IL-6, what I told previously. And coming to chylothorax. Chylothorax, this is very rare, very rarely seen, but I have seen more than 5 cases. Out of this, like it basically presence of chyle in the pleural space. Normally, most of the if it is white milky initially, like before post-op, then it is very easy to diagnose. But if the patient comes post-trauma with chylothorax, after 10 days, it is very difficult because the patient symptoms are different, and history, based on the history only, history also will be different. And chylothorax related rare causes of pleural effusion. Most common chylothorax today malignancy and non-Hodgkin's lymphoma. Chylothorax reports cardiothoracic surgeries, esophagotomy, and surgery for congenital heart disease being the most common cause. Pathogenesis, like it develops the well-developed thoracic that travels through the aortic hiatus of the diaphragm at the level of the 10 to 12 thoracic vertebrae to the right of the aorta. At the level of the 5 to 6 thoracic vertebrae, the duct enters into the left posterior mediastinum and eventually joins to the venous circulation, while the left subclava and internal jugular vein merges both. Normally, the duct below the T5 to T6 causes a right side chylothorax, and wherever as an injury to the duct above this level results in left side chylothorax. Normally, chyle consistence, what they have 2 types, like long chain and middle chain. Long chain is fat ingestion of fat transformed into the chylomicrons and low density lipoprotein in the intestine and from the chyle, whereas this is directly absorbed in the portal vein without entering into the intestinal lymph. Approximately 60% of the diet fat enters the lymphatics, and 1,500 to 2,000 of chyle travels daily through these vessels. Clinical presentation, as based on the history what I told, and stated previous what it happens, and it typically includes the it causes. Based on the history only, like for example, post cardiac surgeries after a day, drain if whitish fluid not associated with fever, if a dye with fat meal or dye is visible in the pleural fluid. Always the surgical repair of the thoracic duct is the one of the treatment. But other like analysis, coming to other, I'll tell you analysis all color. It's always white, and then nucleate cells count always from 4,000 to 600, and pleural fluid protein has been reported 2.5 to 5 grams per deciliter, whereas triglycerides levels greater than 110 milligram per deciliter, they are high likelihood of patient having chylothorax. And triglycerides, if it is less, it is unlikely. And there are two types like here, like chylo and pseudo chylo. Always chylo and pseudo chylothorax. And chylothorax, normally whatever we see, the triglycerides level, if it is more than 400, and the common history with thoracic duct rupture. Whereas pseudo chylothorax, there will be a long standing pleural fluid. Whenever the patient is having long standard pleural fluid, there will be large amount of cholesterol and listin globulins also, or it or cholesterol. In both of that, any one of the may be present, and based on that accumulation, with that compound accumulation only, we can tell it is as it is a pseudocylothorax. And if the patient has a value between the 50 and 110, the lipoprotein ultraphorus should be performed. If the chylomicrons are present, the diagnosis of the chylothorax is definitive and established. Management, supplement patient drain by putting the drain and the nutritional support. And chylothorax should be avoided to prevent, and long-standing drainage should be avoided to prevent the immunosuppressed state and malnutrition. Normally, post-traumatic resolves within, if the case of post-traumatic, it resolves by its own, but sometimes it may not resolve. Then we have to use somatostatin analogs like octreotide. If we use, then the chances of chyle accumulation will be less, and it resolves slowly. Or else the surgical management. In case of lymphomas or malignant chylothorax, they respond with chemotherapy or radiotherapy. Pancreapleuritic fistula. Normally, pleural fluids are complicated, well-known complication of pancreatitis. In acute pancreatitis, may develop small. Later on, commonly we can see in the left side. And pleural effusions for pancreapleuritic fistula associated with chronic pancreatitis are less common, and typically recurs. And pancreatopleurofistulas most commonly occur with chronic alcohols. This is one of the case, like he is a known case of like admitted with epigastric pain. On evaluation, it is acute pancreatitis. He was treated for acute pancreatitis, but after third week again he was readmitted with chest pain and same complaint, epigastric pain. And on CT, when they got CT done, this was the abdominal CT with chest they have done. Here the left side effusion. He was after discharge also, he was continuing that alcohol. So he has developed a pleural effusion. What this we can tell it is a recurrence of pleural effusion in alcohols, pancreatic pleural effusion. This is the CT where he underwent a necrosectomy also, this patient. Coming to renal causes, anasarca, rule outs always we should, and there is a patient on a clinical examination, if he's having anasarca, we should always get all the tests done, like blooduria, serum creatinine, urine albumin, protein, serum protein, and HB. When always sorry, this is the pathogenesis. I missed the slide. Pathogenesis, when in pancreas there is pseudocyst, actually there will be a collection of fluid and debrids located within of juxtapose of the pancreas that contains high concentration of pancreatic enzyme. Half of those are pseudocysts, develops pleural effusion. And the clinical presentation, history of alcoholism, dyspnea, chest discomfort, and unilateral left side. And analysis always it is neutrophilic predominance. and extract with extreme, and MLA is always greater than 1,000, 1 lakh. Other causes MLA is rich pleural fluid is malignancy and esophageal ruptures. And conservative treatment for 2 weeks and not responding, surgical intervention. To summarize, like these all three entries, ADA and interferon, reasonably accurate to detect the TB. Look for the always other causes of lymphatic pleural effusions and post-thoracic surgeries and malignant unilateral whitish. Think of only like chylothorax, alcohol unilateral pleural effusion, especially left side, and high neutrophil content with pancreatic causes. When coming to cardiac bilateral, always they present with bilateral. Always we should get ECG and 2D echo done and chest X-ray. Chest X-ray we can see the cardiomegaly with pleural effusion. Coming to abdominal pathology, liver, pancreas, tumors, all we have to think of. Malignant pleural effusions always they might be unilateral, massive, recurrence, and hemorrhagic. Management treat the underlying cause. Pleural fluid aspiration if the patient is symptomatic. If he's asymptomatic, does never touch the patient. Steroids to enhance the absorption of the pleural fluid. This is one of the other case where the patient presented with fever and dyspnea. After 1 month, initially he had a fever and chest pain. For 3 days, it got subsided. It is basically a encysted pleural effusion. This is his X-ray. But pleural fluid analysis showed PCR with the low value of tuberculosis. This is another case, in pediatric case, parapneumonic effusion. Initially, he came with pneumonia. Later on, he developed loculated parapneumonic effusion. Patient continued to be fever consistently. It was not coming down since 2 days, in spite of all the NSAIDs. And patient had underwent VATS. Now he improved. He is doing well. Thank you.
Thank you, Ramu. Very extensively elaborated on the pleural fluid and etiology, clinical picture, and differentiation of all these different types of pleural collections. Yeah, you showed on one slide, no, the central line in the pleura. Ramu,
Idi sir.
Central line,
Sir.
అంటే స్టార్టింగ్ లో పిక్చర్ అది కాదు, ఎక్స్రే కాదు కానీ బట్
Yes, sir.
Okay, it's okay. So there is one incident happened in Vizag. After putting the central line, there is a blood flow from one port, 2 ports, and there is no blood flow or aspiration in another port. So because our 2 ports are working, they connected the fluids and inotropes in the 2 ports. Later patient is not improving and deteriorating day by day, and X-ray shows, as you said, there's a massive effusion on the whiteout on one side, right side. Then they did the CT scan. CT shows the completely. After that, they stopped checking the ports because the inotropes are going, no, so they didn't aspirate anything. And patient is a complete CT central line in the pleura. And a patient died, the VIP patient, and that is completely in the pleura. My suggestion here to, whenever the ports, 3 ports are not working after manipulations or adjustments, better to remove that central line and replace it.
Okay, sir.
Because you mentioned in one slide, that starting slide only,
Is there, sir. Adi diagnostic importance learn better, sir.
Correct.
Last one.
Last point.
Last slide. Unna, sir. First one unna.
Yeah.
Always rails to mediastinum side nunchi shift vastadi.
It's okay. Any questions? Our later Jekina.
Anna. Good morning, Anna. Surendra, it's a nice class. And how do you diagnose chylothorax and how do you treat the chylothorax?
Sir, chylothorax normally what my sir said, like we can bedside one test is there, sir. If you take ether and chyle, the chyle will dissolve in that ether. Ether untad ka sir. Ether ni తీసుకొని chyle మనం తీసుకున్న fluid, if you keep in that, that get dissolved, sir. It becomes like water. That is the bedside diagnostic test, sir. And always we have to think of history first, sir. Basic history. And second thing is what any surgeries, what I told in the slide. And treat is first always
from chylothorax, from where it is leaking, how will you know? But the chyle we have diagnosed the chyle.
Yes, sir.
So chyle because of its color and by I mean more triglycerides ఉంటాయి కదా complete గా.
Yes, sir. Triglycerides ఎక్కువ ఉంటాయి, sir. Levels
when compared with the serum levels, we compare it with.
Yes, sir.
And then we diagnose it as a chylothorax.
Yes, sir.
So from where it is leaking, how will you know? I am getting approximately around 600-700 ml of chyle. How will you stop it?
One thing is management side, sir. Diagnostic కాకుండా management side అయితే by diagnosis we should only, the thing is if it is big one we should open, sir. That is only the, and to what my experience I have seen, to detect it is very difficult on table what sir has told, SBR nursing, sir. To pick that vessel wherever the lymph is there, it is to pick that, it is very difficult itself. So normally they wait for 10 to 14 days, what I told. We have waited for that all these 4-5 cases.
Can we do a lymph angiogram in the patients?
We can do, sir, but what we do the next, sir? What next we do? If it is large, then we can ligate it. If it is small thing.
No, first we need to identify from where it is. Then the treatment part is what
treatment part, wait and watch, sir. First.
Any specific things to give?
Specific nutrient supplements, sir. Like avoid like
fatty acids.
Fatty acids avoid. Sir. And always we give this, what I told is stomatostatin analogs. Octreotide we can give, sir. We tried in one patient, it had
TPN also, no?
Sir?
TPN supplementation for this patient.
TPN,
TPN, fatty acids.
TPN లో ఫ్యాట్ ఉంటుంది కదా సార్ కొంచెం,
అంటే సెపరేట్ గా మరలా.
మీకు సార్ మీకు గుర్తుందో లేదో సార్ ఐస్ క్రీమ్ కూడా తినిపించారు.
అదే అది ప్యూర్ ఎంసిటి అని ఉంటుంది కదా పౌడర్.
అవును సార్, ఎంసిటి పౌడర్.
ఎంసిటి యు హావ్ టు గివ్ అట్లీస్ట్ 2 bottles per day. Yeah, we treated one patient, SBR nursing home. So it is stopped after 2 weeks. For one patient recently in Pinnacle.
Surendra. That's Surendra. Hello? Hello, Surendra.
Can you see any effusion in COVID patients?
Yes, sir. Yes, sir.
Previously, they used to tell if there is if there is a pleural effusion, you can rule out COVID. But I have seen a lot of COVID patients with pleural effusion. Can you explain that?
నార్మల్గా దే మే డెవలప్ విత్ అదర్ అంటే డెఫినెట్ గా అయితే కోవిడ్ అయితే ఉండదు సార్, రూల్ అవుట్ అయిపోతుంది. కానీ కొంతమందికి లంగ్ లోని ఫైబ్రోసిస్ కానీ ఏమైనా అండర్లైన్ డిసీజ్ ఏమైనా ఉంటే అలాంటి వాళ్ళకి ఛాన్సెస్ ఆఫ్ డెవలప్ ప్లూరల్ ఎఫ్యూజన్ ఉంటుంది. ఎందుకంటే అప్పుడు హార్ట్ ఫెయిల్యూర్ అలాంటి వాళ్ళకి ఉన్న ఎఫ్యూజన్ డెవలప్ అవుతుంది. అది కోవిడ్ అని పాజిటివ్ ఉండి అది ప్లూరల్ ఎఫ్యూజన్ ఉంటుంది. అప్పుడు మనం డిఫరెన్షియేట్ చేయలేం కదా సార్.
Maybe no, not having any history of heart failure or tuberculosis. No history actually.
Normal
They
patient, no
presented with
comorbidities patient.
normal patient, 45 years old female, presented with cough, fever, and breathlessness. Yeah, okay. CT shows pleural effusion, but GGOs are there. So GGOs are there. It is a feature of COVID. At the same time, bilateral mild to moderate effusion also is there. So we did the RT-PCR, it is positive. Number of cases I have seen.
చూడలేదు సార్, అంటే ఎఫ్యూజన్ విత్
నేను చూశాను.
ఓకే.
Anybody having that experience? మీరు కానీ
మేబీ ఇట్ ఈస్ అసోసియేటెడ్ విత్ అదర్ కండిషన్స్ ఆల్సో ఉండొచ్చు. మరి యూజువల్లీ అంటే ప్లూరల్ ఎఫ్యూషన్ మినిమల్ ఉండొచ్చు, బట్ ఎక్కువైతే ఏం చూడలేదు నేను కూడా.
పర్సే కోవిడ్ వైరల్ ది రాదు సార్ నార్మల్ గా.
ఎఫ్యూజన్ ఉంటే యూ కెన్ రూల్ అవుట్ అన్నారు కానీ, బట్ ఐ డోంట్ థింక్ యూ కెనాట్ రూల్ అవుట్ అన్లెస్ యూ డూ ద RT-PCR.
అంటే మీరు జీజీఓస్ ఉన్నాయి కాబట్టి పీసీఆర్ చేశారు కదా సార్, జీజీఓస్ లేకపోతే
చేసేవాళ్ళం అప్పుడు. బికాస్ ఆఫ్ ఫీవర్, ఎవ్రీబడి కమ్స్ విత్ ఫీవర్, కాఫ్, ఇట్ ఈస్ కోవిడ్. అన్లెస్ అదర్వైజ్ ఇట్ ఈస్ రూల్డ్ అవుట్. అంతే కదా. మేబీ మీరు చెప్పినట్టు ఈ మైట్ బి హ్యావింగ్ సమ్ అదర్ డిసీజెస్ అండ్ హీ గాట్ కోవిడ్.
మిక్స్డ్ ఉంటది సార్, చాలా కొంతమంది మిక్స్డ్ లో వస్తారు.
అన్నా చెప్పన్నా.
హలో, అంటే మనకున్న ఎక్స్పీరియన్స్ లో కోవిడ్ కి ఎక్స్క్లూషన్ క్రైటీరియా అంటూ ఏం లేదు. ఎనీథింగ్ కెన్ బి ప్రెజెంటెడ్ యాజ్ కోవిడ్.
అవును,
అది అంటే వి కాంట్ సే ఇది ఉంది కాబట్టి కోవిడ్ కాదు అని చెప్పడానికి అంటూ ఏమీ లేదేమో అనుకో.
ఏమీ లేదు,
అది ఆల్ మిక్స్డ్ పిక్చర్. ఎనీథింగ్ కెన్ హ్యాపెన్ ఇన్ కోవిడ్. వాట్ ఎవర్ దట్ ఈస్ పాజిటివ్లీ సీన్ విల్, అంటే threshold to diagnose COVID is very low. Highly, any patient can be called as COVID if the RT-PCR is positive. He might present to us with any sort of symptom or any sort of
symptoms also they have COVID.
Yes,
accidentally family members got, so there are no symptoms, but he also positive COVID. There are so many.
Yeah,
so no symptoms to even symptoms leads to death. Nice class, Ramu.
Sir,
now what is your prediction on this new variant? Is it going to come very fast? China,
yeah,
it
yes.
is,
We have seen one patient. We are not sure because of certain issues, but 2 days back one patient was diagnosed to have COVID with milder symptoms. We don't know the strain, but the patient has history. Recently he came from China. 4 days back he came from China.
Definitely.
So problem ఏంటంటే we have a better experience. Once we diagnosed it, ours was the first case in Hyderabad, combined states, in 2020. So we gone through a lot of governmental issues. So DMHO sitting on my head, medical health, whole system of state government were with us. They were bombarding us. So this time I don't want to commit myself that I have a case and I haven't sent it to even that is a gene analysis. But cases are coming up in Hyderabad.
Central government given no order to genomic sequence.
Yes. So we have sent that patient silently, go to any other hospital and get it verified.
Sir, genomic sequences you are doing, sir?
ఇక్కడ చేస్తారు సార్ ICMR.
Sir, government is asking to send to specific center or
ICMR sir, our ICT CCMB.
సిసిఎంబి అందరి. సో పాజిటివ్ వచ్చిన వాళ్ళందరూ కంపల్సరీ సిసిఎంబి పోవాలి.
పోవాలి సార్. అవును.
All yesterday given orders to do.
అది
What is the virulence of this new variant EF7? దాని పేరేంటి?
BB7 కదా.
Yeah, because so many deaths are happening in China because of this variant, or
No, there is a contradictory discussion happening that China people were not so far they didn't have the self immunity. They were so tight previously, and suddenly they lifted out the ban of mask and social distancing. So they were not actually protected as India was protected. We are almost like India got vaccinated.
correct?
So-
వాళ్ళు కూడా they had so many deaths in the first wave, no, in the beginning.
But they were not vaccinated and they were not developed self immunity.
They're not
Because of-
vaccinated,
They were not there. China vaccines are nonsense vaccines. They are not RNA vaccines. They are not spike vaccines. So something, and it is being proven that their vaccine efficacy is very low, and they didn't develop any self immunity because of their highly restricted self distancing and masking. So ultimately, in India, we are very good in vaccination. And second thing is, we slowly got out of this mask and this thing, and self developed immunity was there. So getting the, but R ratio, R dash is 18. One patient can infect 18 people at the present thing.
R dot is 18.
18.
ఎవరికి?
ఇప్పుడు present virus
Very severe, no? Very high.
very high. So even though if it is infection will be there in India, but may not be virulent because of the either it is development of the self immunity or vaccinated immunity.
సో వస్తే ఒక 1 month లో అయిపోతుంది
అయిపోవాలి
హోల్ ఇండియా.
సార్.
కానీ అదర్ కంట్రీస్ ఆర్ ఆల్సో హ్యావింగ్ సార్.
సార్
అదర్ కంట్రీస్ ఆర్ ఆల్సో ఎఫెక్టెడ్ కదా.
అవును సార్, బట్ ఎక్కడ మీకు చైనాలో వచ్చినంత ర్యాంపెంట్ గా లేదు చూడండి.
లేదు,
చైనా
లేదు.
చైనా is
That's
again
also very
dead
less
bodies.
in other countries.
చైనాలో పేషెంట్స్ ఆర్ లివింగ్ విత్ డెడ్ బాడీస్ ఇన్ హాస్పిటల్. వాట్ వి ఫేస్డ్ ఇన్ అవర్ సెకండ్ వేవ్.
ఓకే.
సో అంత సీరియస్నెస్ లేదు కదా.
Okay, Anna. Thank you.
సరే, bye bye.
Thank you, Ramu. Thank you all
Thank
for
you.
your
Thank
active
you, sir.
participation.
Bye.
Thank you, Ramu, for a nice presentation.
Thank you.
Thank you.